Good afternoon. My name is Renee Cowan. I am a GYN oncologist at Women's Hospital in Baton Rouge. So I'm coming from right up the street. Our patients are destroyed for a lack of knowledge. That is what it really comes down to when it comes to ovarian cancer. This is where what we don't know can indeed hurt us. I have no disclosures. Today, we're just going to do a brief review on the background of ovarian cancer and discuss some of the gaps that we have in our knowledge and identify some areas for growth. So, what is ovarian cancer? Here we've got a picture of the uterus, a fallopian tube, and ovary. And essentially, you have abnormal cells that develop either inside or on the surface of the ovary. And because those ovaries are really hanging out free in the abdominal and pelvic cavity, all those abnormal cells have an opportunity to spread throughout the abdomen and the peritoneum. So in the bottom corner here, you see a picture of, that's actually the diaphragm or some of the tissue that's on the diaphragm and what it looks like when we open a belly and there's cancer that has gone from the pelvis all the way up to the top of the abdomen. And so this is what we face well, not every day, but this is what we face pretty often at work. And we're like, well, what do we do from here? Well, what about here in Louisiana? We're not like them, or are we? So, ovary cancer is one of the most lethal GYN cancers. It is not as common as endometrial, but it is very lethal. In the United States, it accounts for the death of about 7 to 8 women per 100,000 each year. And about 14,000, and that number raises, women die from this every year. Overall, the 5-year survival in this country is 46.5%. And so that's a pretty dismal number. That's not what we want to see. And like I showed in the picture prior, most of these diagnoses occur after the disease is already spread. And that is when our survival rates start declining. So as you can see from the graph down in the bottom right corner, if we find these cancers early, they have a higher rate of survival. If they're just in the pelvis, still have higher rates of survival. When we find them distant, like the pictures from the disease in the diaphragm, your rates of survival decrease. What about here in Louisiana? We're looking at about 250 cases each year. And since 2000, we've had almost 2,000 women survive ovarian cancer since 2000. Our 5-year survival is very similar to the national numbers, 44%. Ovary cancer is the 5th leading cause of cancer death among women in Louisiana. And unfortunately, we are ranking at number 42 out of the 50 states for getting our patients to live. What is good is that you can see that this disparity between Black and white is not as big in Louisiana as it is in some other places. So we can feel a little bit better about that, and that our rates of death the disparity between our Black patients and our white patients isn't as high. Risk factors. There is a family history of inherited genes. There's obesity, which we have a little bit of an issue with, hormone replacement therapy, and endometriosis. So all of those things can predispose one of your patients or yourself or somebody in your family to an ovary cancer. When we look here more at the Louisiana Tumor Registry, we can see that the vast majority, again, of our patients are diagnosed with distant disease, 52%. So over half of the patients who come into our office with an ovary cancer diagnosis are going to already have distant disease. However, we do have a 22%, almost a fifth of our patients who come in the early stages. So that is good. So how are we treating ovary cancer? Ovary cancer is treated with a combination of chemotherapy and surgery. It's all a matter of what comes first, chicken or egg or chicken. We kind of have to decide based on patient factors. Are we just going to try to cut everything out, take everything out, or are we going to use some of these drugs that we have as to help us modify our surgeries? And this is something that ongoing debate, but at the end of the day, it's a very personal decision between the physician, the surgeon, the person giving the chemotherapy, and the patient. And it's very specific to each patient what actually needs to happen first. All the debates, all the years, all of our advances. We've got advanced imaging, we've got different biomarkers, we've got different therapies, chemotherapies, immunotherapies, all of the things that we just kind of reviewed, kind of similar in ovary cancer. But after all of that research, when it comes down to it for ovary cancer, the backbone of our treatment really hasn't changed. It's surgery and chemotherapy at the end of the day. That's what we have. So what is it that we don't know? We don't know much about how do we screen? Can we screen? Who should take care of the patients? Where are the GYN oncologists in Louisiana even located? How do we get our patients to those GYN oncologists? How do we keep Louisianians in Louisiana? We don't want our patients going to our neighbors to get care. We want to keep them here and take good care of them. Where are the clinical trials that we went through hordes of clinical trials just now. There are many for ovary. Where are those trials? What are the epidemiological differences? Why is it that our disparities aren't as great here as they are in some other parts of the country? Or is it that we're not studying them and they are great? So what are those differences? What are the newest and best drugs? Can we do something to change that backbone? So I've broken it down into kind of education piece. We've got to start by educating our patients, right? Because they're the ones who are experiencing it. And honestly, it starts with them. You see something, you say something, what do you do about that thing? How is it that we can let our patients know what their risk factors are? What are their risk factors? Or do you have endometriosis? Has anyone ever told you that? Do you have a family history? Do our patients know their family histories? Do you know your family history? What is this Pap test? So many patients will come into our office and be like, oh, I can't have cancer. I had a Pap test. Ma'am, that's not what that was for. And there's so many of us and so many of them who just don't know. Whether they have ovaries or not. They've had a surgery. Oh, they had surgery some time ago and some guy did it and it was for bleeding and this happened or blah, blah, blah. Do I have ovaries? I don't know if I have ovaries. They took out my ovaries. I can't have ovary cancer. Ma'am, you have ovaries and you have ovary cancer. Where do we go from there? Symptoms, this bloating, this indescribable feeling, something just didn't feel right, something is just weird. What does that mean? What does that feeling mean? Who should I tell about it? Should I tell somebody about it? Oh, it's just normal. These are the things that we're facing, and these are the things that we have to educate ourselves on, our peers on, our patients on, that really this is where it starts. Then once they get to their providers, whether that be a mid-level provider, a nurse, a sister friend who happens to be in nursing adjacent school, everyone has to know how to help direct these patients to where they need to be. What are our genetic testing options? Do we know as providers what those options are? How to get our patients those options? Do we know who to refer patients to? Think about if someone came into your office, into your room, into where you work, and had this issue, would you know who to send them to? Would you know where to get them started? When do we refer the patients? Can I myself take care of this issue? Can my local GYN take care of this issue? Or does it actually need subspecialty care? And I think that that's something that we fight as GYN oncologists all the time. Hey, we're here. This is what we do. We know how to take care of it. Send them to us. And it's hard because there aren't a lot of us. There's, just 4 in Baton Rouge, maybe 10 in New Orleans, 1 in North Louisiana. That's it to cover the whole state. And so we've really got to know that we exist, the less than 20 of us exist, and we are here to take care of those 20,000 women. And to make sure that they are treated and get the guideline adherent care that they need that will help increase our survival numbers. Access to care. What do we actually know about our access to care? We have the lovely chart that Dr. Jernigan showed earlier with the cervix cancer and the food and what do we have for ovary? What does it mean for our patients to get care? What do they have to overcome to get care? What changes can we make to make sure that they can get care? that they don't have to drive to Texas, that they don't have to go to a surgeon who's never seen ovary cancer before. Because again, those numbers are small considering what other cancers we may see. This is a rare entity, but there are people who specialize in this rare entity, and for us, it is not rare. So what does it mean to get our rural patients care in places in more urban settings? Do our urban patients even know where they are getting their care or how to get their care? Are there actually racial disparities that we're not accounting for, that we're not seeing? Or is there a reason that we're not seeing them here? What does that mean? These are the questions that we have to ask ourselves. Are there socioeconomic disparities? Because trust me, cancer does not care how much money you make. It doesn't care at all. So what are the disparities, and how can we make sure that we even out the playing field? Which are our patients that are not being served? Who's not getting the care, and how do we make sure that they get the care? And again, I've said this multiple times, who are we losing to our neighboring states, and how do we keep them here? Specifically, how does the cancer that we see here compare to that in other parts of the country? Now, I have trained in the Northeast, and it's just a little bit different there. And you come here and the patients are different and the disease is different. The pathology is different. I spend a lot of time talking to the colleagues that I trained with, and they talk about, oh, carcinosarcoma, I've never seen that. Girl, we see that every day. Why is that? What is going on here that our pathology is different? And then if our studies are based on the things that they're doing there, are our patients being really treated? Are they being represented? And that's not a black-white thing. That's not a socioeconomic thing. That's sheerly regional. What is contributing to our cancer alley? What is making it exactly that way? And what do we need to tell the people in Baton Rouge, or the people who make rules and decisions and legislator? What do we need to tell them to fix that? This is not something we want to be proud of. This is something we want to address and fix. And are the national studies reproducible? Are the studies that Kaiser does in California, can we talk about, are patients like that? We're not like them. So we need to make sure that our studies represent who we have here and what we see here. Solutions. What are our ideas? What can we say? What can we do? We need to increase awareness, which I think I've said a million times now. The role and importance of GYN oncology. We are a field wholly and totally dedicated to treating women's cancers. There is no one better fit to treat a woman's cancer other than a GYN oncologist, and that is across the board. So if that means that your patient needs to travel 2, 3, 4 hours to get to a GYN oncologist, somehow we have to convey to her that that is worth it and that her life does indeed actually depend on it. There are multiple studies that show that women have better outcomes when they are treated by a GYN oncologist. Our diseases are not like the diseases in the abdomen. Ovary doesn't act like pancreas. It doesn't act like colon. It's very different. So you need someone who speaks to ovary cancer day in and day out to take care of that. There is a value in genetic testing. Yeah, it's scary. It's scary to know what your genes say, and does that mean that you're passing something on to your children or onto the generation? Is your life insurance gonna mess you up? Are you not gonna get insurance? Yes, it is scary, but again, your life depends on it. Because these are the patients, when we find genetic alterations, those are the patients who we can do things about. We can make them live longer. We can take out things, we can decrease their risk of having things happen to them. And so we really want to emphasize to our patients, to our peers, to our colleagues, the value of genetic testing. Knowing your family history. Nobody likes to talk about the GYN organs. Nobody likes to talk about the vagina or the ovary or any of those things. And so if you have a family member that's gotten a cancer in one of those areas, Auntie does not want to talk about it. Grandma doesn't want to tell you. But you knowing that can change the course for your life and for your children. And these are the things we have to share with each other and with our patients. And the disease complexity. Our disease is complex. It is not simple. The ovaries are the birthplace of life. This is where life starts. And so we know that this is not a simple thing. And that means that complex problems require complex solutions. We need to increase access. We need to improve our models of care, centralization, regionalization. What does that mean? If that means that I need to ship all of my patients to New Orleans, if that is going to get them a better life, I am willing to do that. For the patients who aren't willing to do that, does that mean that we will go, and we do go? Do we go out to Lake Charles and Lafayette and all those other areas? We will go to where the patients are. We need to be able to centralize our care and make sure that we can serve our entire state. We have to be able to improve payment structures. We need to improve and increase the insurance coverage for GYN oncology and for GYN specifically. Oftentimes, we are able to get things covered as GYN oncologists because we're cancer doctors and we throw around words and we have a staff that'll call and do the things with the insurance company. What's it called? Yes, they'll do those things, right? Fine. But we're talking about our regular GYNs who have full clinics, all this staff. They want to take care of their patients. But there are so many hurdles to taking care of patients. Many of us go to Lafayette, and we are probably the only people in Lafayette who provide Medicare service. We see so many things that are not cancer just because we're the only ones who take that insurance. That is not okay. Those patients deserve better care because I am not the right person to be taking care of your regular general GYN needs. That's not me. I'm not the right person for that. But that person still needs care. And so how do we get them care at a ground level so that then they maybe don't have to ever make it to us? And then expanding and enhancing the GYN oncology workforce. I alluded to it earlier, but we are a small subspecialty and we are not very highly represented in Louisiana where there is a cancer alley and definite a clear need. How do we attract people into this workforce? How do we attract people to our state? How do we get them to stay and take care of our patients? We need to increase funding. Clinical trials, clinical trials, clinical trials. And I think that is something that we will hammer home over and over and over again. But obviously funding is important for clinical trials because clinical trials mean clinical discoveries. It means new medications and therapies. We need cancer centers, places where a patient can go, a woman can go and be taken care of as a whole woman. She doesn't have to drive all over town to get piecemeal care here and there and here. That's the point of a cancer center, and cancer centers are associated with increased survival. Places where they offer research and offer clinical trials, increase survival. Places where they do those things also have caretaker support. You're surrounded by people who look and feel like you, who are going through similar things that you're going through, who their friends, their families, they know what they're going through. And all of those things improve the quality of life and improve survival. So now that we've been able to talk about what ovarian cancer is, what we know and what we don't know, and how we can improve those gaps in our knowledge, it's time for us to take it to the streets. Take what you know, take what you learn, take it out there and encourage more knowledge, more awareness, and let's bring our numbers up. Let's not be 42. Let's aim for, number 1. Any questions?